We're going to be talking about strokes today. I appreciate you all coming, and hopefully you can help a neighbor with what you're learning today. Again, thanks, Kim, for asking me to come. And I am Rachel Rettig. I am a board-certified emergency medicine physician. I've been practicing for 11 years, 7 of which have been here. I am our director for the emergency room, for our EMS system, along with several of the small systems in our area. So chances are if you need an ambulance, I'm probably in charge of them. And then as well as our Ready Care department, I help oversee the care that you get at our walk-in Ready Care department as well. Part of my role as the ER director is the trauma and stroke programs. So these are programs through the state that have a lot of requirements, but it's to hold us to a standard so that when you need to come and see us for a trauma or for a stroke, that we are meeting all of the requirements that we need to meet, that we are looking back at every single one of those cases I review and we see what could we have done better to help improve our care for the next time. And so that's why you're hearing from me, is that stroke is part of one of those hats that I wear. So we'll talk about stroke as we go. So the biggest thing for everyone is that stroke happens to anyone at any time. It doesn't matter what race, what sex, what age, it doesn't matter. So just because you're 25 and you have stroke-like symptoms, it certainly can still be a stroke. And so everyone from in utero to 100 and whatever can all have a stroke. And so we want to teach you how to recognize those symptoms so that whether it's in yourself or whether it's in your neighbor or whether it's in your family member, you can help to get them the help that they need and get them as fast as possible to us in the emergency room. So our goals today are to recognize those signs and symptoms, which sounds like it should be easy, but it really isn't some of the time, and we'll talk about that. Then to know your own risk, and that's part of the paperwork that you have in front of you that you can look at as we go. And then how do we help minimize those risks so that you aren't one of the statistics that we're talking about. So why do we care? Why are we worried about this? Why are we all sitting here having this lunch and listening to me talk? So stroke is a huge disease that affects very high numbers. It costs a lot of money to our system, and it causes a lot of disability to the people that it affects. So over 800,000 people a year experience a stroke. It is the 5th leading cause of death, the 6th in Minnesota. 15% of strokes that occur happen in children and adults less than 40. So that's a huge number. Consider those numbers when we talk about anyone can have a stroke. This occurs once every 40 seconds. One of the biggest things that I find when I talk to people who are having a stroke is that they are worried about their disability. No one wants to die, I understand that. But even more so is you don't get to live the life that you thought you would be living. You are out and active and golfing 3 times a week and taking care of your grandkids, and then a stroke hits and now you're potentially not able to walk or not able to feed yourself or those type of things that really affect your day-to-day life, which is why we talk about this. It's a huge leading cause of long-term disability. It is also the leading preventable cause of disability, and 80% of those strokes that happen are preventable, and that's why we talk about what can we do to help not be a statistic. $45 billion in annual stroke-related medical costs. As you can understand, both the cost of needing to, ambulance ride in and ER and transfers and procedures and all of those things, but long-term now, we're talking long-term care and therapy and so on and so forth. It's a huge cost. So what is a stroke? And we talk about those blood vessels, arteries, arterioles, all of those, the blood vessels that bring the nutrients that your brain needs to function as it's supposed to function. Something happens to those arteries, and there are different kinds of strokes that we'll talk about, but whether this is a clot or whether this is an artery that bursts, the vessels that are supposed to carry the nutrients to the brain tissue, something happens to them and now that brain tissue is not getting the blood flow that it needs. That's what causes a stroke. We think of the same thing when you think of a heart attack. The arteries of your heart get blocked and now the muscle downstream isn't getting the blood flow that it needs to function. Think of a stroke just like you would a heart attack. It's a brain attack. So it's a problem with the arteries now that the brain tissue can't get the nutrients that it needs. So how are you going to know? And this sounds like it should be way easier than it actually is. And many of us are familiar with the classic signs of a stroke. Facial droop, our arm or our leg is weak, or we're talking gibberish, right? Those are kind of the more typical that we see. The problem is that depending on what area of the brain isn't getting the blood flow that it needs, will affect what symptoms you see. And so if you're sitting there with Aunt Betty and Aunt Betty starts to have a facial droop and her arm is weak, well, yeah, that's pretty classic stroke. It's a little bit harder to recognize when Aunt Betty stands up from her chair and she's off balance and tipping to the side or can't quite get her feet under her. That's a lot more vague, but that also is certainly a sign of a stroke. So it used to be, many of you are familiar with the FAST, and it was in the name of the title. So face, arm, speech, and then time, which we'll talk about. We've actually taken that FAST mnemonic and changed it a little bit more to be more encompassing, because when we talk about the posterior circulation, the back part of the brain much more affects your balance, which is the easy one to miss. It's easy for physicians to miss it. It's definitely easy for you as Betty's friend to notice it. So when you have an acute change in your balance, certainly that's suspicious of a stroke. It can be from many other things, but it's certainly suspicious of a stroke. When you have a vision change, specifically one eye suddenly goes blank and black and you can't see out of one eye, that's very classic of a stroke that specifically affects the eye. That might be their only symptom, is visual, but it typically is to one eye. You can also lose certain visual fields. So if there's an acute change in your vision where now you can't see, your peripheral vision on one side and the inner vision on the other or similar, that also is a sign of a stroke. And then our FAST, like we talked about, our facial droop. You might ask Aunt Betty to smile and her side is drooping or she's drooling out of the side of her mouth. Your arm or your leg, you say hold up your arms and that wants to droop, along with a sudden change in their speech. They've got slurred speech. They're talking word salad. The words that are coming out of their mouth make no sense to what we're talking about, or an acute confusion, or a lot of the times the most common speech change besides slurred speech is expressive aphasia, we call it. You can't get out what you're trying to say, and it's very frustrating for the person that it's affecting. You're trying to say how you're feeling or come up with a word and you can't find it and you can't get those words out of your mouth. So acute changes with that. And then last is the time. So strokes specifically, along with many other things, but specifically with stroke, is the earlier that you can get them to the medical care that they need. Many of our treatments, pretty much all of our treatments, are time dependent. And so it's very important that you're not sitting there and saying, well, why don't we go take a nap and let's see if it's better when I wake up, which we hear all the time. And then unfortunately, now you're outside of the window of things that I could have done to help you. So when you see this isn't the type of thing where we say, well, let's give it 6 hours, and if I'm not better, we'll come in. When you see stroke-like symptoms, you need to call, and you need to call right away. So, as I said, stroke is an emergency, and we very much want you to call 911. I know many people hesitate to call. Let me tell you, this is the one thing, one of many, but one thing for sure that we want you to call, because then we are prepared, we're ready, everything is time dependent when it comes to a stroke, and so this is the fastest way for us to get you the help and get you the help that you need timely. You don't call your doctor, you don't call to the clinic. I can guarantee you they're sending you to me. So don't call the clinic, you call 911, you come into the ER. You don't pass go, you don't collect $200, you call and you call now. Time is brain, and you've maybe heard that when it comes to heart attacks. Time is muscle is what we say to that. You have an area of your heart that's not getting the muscle that it needs. That muscle dies if you don't hurry up and get it what it needs. Your brain, same thing goes. If that's not getting the blood flow, that brain tissue is going to die until it gets the blood flow that it needs. And that's our goal, is to get that blood flow back where it needs to be. So time is brain. We say that about 1.9 million neurons is lost every minute that your brain doesn't have the oxygen that it needs. So when you call 911, we don't want you to say, oh, I just don't feel right, or something's wrong. I want you to say, I think I'm having a stroke, or Aunt Betty looks like she's having a stroke, and they're gonna dispatch an ambulance to you. They ask a lot of questions and very specific questions, and they're not gonna, hold your hand and make you feel a lot better. Our goal is to find out exactly what we need to know and to get you to me as fast as can happen. So they're gonna do a lot of the physical exam quickly. They're gonna poke you for a blood sugar quickly. They're going to put you on a monitor and get their EKG, and then they're going to get you to me. And they're going to call in and they're going to say, I have Aunt Betty who has a facial droop and arm weakness that started 30 minutes prior to arrival. Her blood sugar is okay. Her blood pressure is 190/90, which is what your body does to try and keep your brain perfused. We won't treat that. We want it to be high. And they're going to drive fast and they're going to get you to me. When you come into the ER, when you're with Aunt Betty or you are Aunt Betty, we're going to do, again, a lot of things that happen really quickly when you come in. And sometimes family won't be right there with us, but we're very focused on Aunt Betty, and there are a lot of things that we need to do in a very expedited time. And so you're going to come into one of our main rooms, and you're going to get all hooked up. Probably the first thing that's going to happen is you're going to be taken straight down to our CAT scan machine, where we're going to do a CAT scan of your brain, and we'll talk about that in a little bit. And then you're going to come back to our room, and you're going to be bombarded by a lot of people doing a lot of different things. We're going to do a lot of that exam quickly. We're going to get you on the monitor and your blood work and your EKG and all of those things that we need to do. And then you're going to see this machine or similar in one of our trauma bays or our big resuscitation bays. And we're very fortunate here for our stroke care. We have what we call telestroke, which is telemedicine with a stroke neurologist. So you have typically been here less than 15 minutes and you've already seen the specialist when you come in here. And that stroke neurologist is going to pop up on the screen, and I'm going to give that stroke neurologist a little quick tutorial of what I've seen and what I know about you so far and what we're seeing. They're going to look at your scan, they're going to look at you, they're going to probably have you do some exam things, and then they're going to make a recommendation based on timeline and your exam and such. So we're very fortunate to have that telestroke capabilities, but it is the best thing for your family to have these specialists seeing you, doing your exam, all usually within about 15 minutes of when you get here. Any questions so far? Otherwise, we're going to move into more of the education of strokes themselves, because a stroke isn't a stroke isn't a stroke.
Can I ask one question?
Yeah.
Is this now the balance of in your ER? I came in a year ago and she missed it, and it was four weeks before I got, and only with a visit to my personal physician, which I had yelled at to get that visit. Was it stroke diagnosed? Because she noticed a slight language delay. I walked into ER, she treated me for vertigo and sent me off. She did no tests. So I'm not worried. I mean, I am fine.
Mm-hmm.
But if your ER is still doing that, then it is wrong.
Yep.
They miss a silent stroke.
Yes, and so this is balance specifically. As I said, it is not an easy diagnosis even for physicians. Balance is the number one thing that is missed, and it is diagnosed as vertigo, as you've just said. It is a very difficult diagnosis to make acutely, and so an acute change in your balance is something that we would need to do some of those testing to look at. And even so, as we'll talk about, a CAT scan is not diagnostic. A diagnostic test for a stroke is an MRI, which is not available 24/7. Yes.
She just prescribed a prescription and shoved me out the door.
Okay, so yes, that is the concern, certainly, and balance is one of those that is a very easily missed stroke.
The other one I have is I did phone the hospital, God knows how many years ago, when my husband was 27, and say he's having a stroke. And the hospital said, he's 27, he can't have a stroke. Fortunately, by this time he was paralyzed on one side and they took him in and it wasn't an aneurysm. But I know another patient that had an aneurysm. The ambulances refuse to come out. If you're young and it's stroke symptoms or headache.
Yeah.
I don't know if that's been corrected.
Yeah, that's not happening any longer, certainly. So if there's anything, of course, that is acute, by all means, if you talk with Kim or myself, we can, of course, look into those things. But yes, 911, when you call, they respond. And I review those cases with EMS as well. But you are right, age is, and there's been a lot of education in the last 20 years when it comes to stroke. Stroke especially, because many of the treatments weren't an option then. And we didn't understand even 20 years ago about the 15% are young. Because you're right, when we say, oh, a 27-year-old with stroke-like symptoms, that doesn't happen. Well, that's wrong. It does happen. It's rare-ish, but not as rare as we would like to think it is. So, no, absolutely. Anything else? Otherwise, we'll move on to types of strokes to talk about. Okay. So when we say Aunt Betty's had a stroke, there's two main categories, so to speak, of types of stroke. The one being ischemic stroke, and that is by far the most common. About 87% are ischemic strokes. The other types of strokes are bleeding strokes, or what we call hemorrhagic strokes. When we talk about ischemic strokes, there's two main kinds, and that is whether it's embolic, meaning that there was a clot somewhere that traveled through a blood vessel and lodged downstream, thinking of, blocking a dam or blocking a river. Maybe it started in the heart. Maybe Aunt Betty had AFib and didn't know she had AFib, and they're at risk for forming clots in their heart, and they flick off a little piece of that, and it travels up into the brain and lodges, and that's how you have an embolic stroke. Thrombotic stroke is more like a typical heart attack type stroke. You have narrowing of an artery, maybe some cholesterol plaques, and that plaque gets disrupted, and it causes a blood clot right in that area. So those are the two types of ischemic strokes. On the other hand, when we talk about bleeding strokes, there's two different kinds, whether we're talking about bleeding in the brain tissue, which our fancy word for that is intraparenchymal or intracerebral, or blood that's on the brain, which is like subarachnoid hemorrhage. Maybe they had an aneurysm that burst or something similar. So talking about ischemic strokes, as we talked about, that's whether either a blood clot or a cholesterol plaque causes it to block up that artery. So whether it travels from a location, whether that is maybe you've got a big narrowing in your carotid artery and you flick off a little plaque that travels up to your brain, or whether it's a clot in your heart and you flick off a piece of that and it embolizes or travels up to the artery of your smaller artery in your brain, or whether you have the narrowing from a plaque in that area that then gets clotted off. When we're treating ischemic strokes, there are a couple of options in treatment, and this is where the time dependence is very important. So our typical medication, if Aunt Betty comes in and she had symptoms starting 30 minutes ago, she's got facial droop, she's got arm weakness, and she comes in and we tell a stroke with that team, as long as there aren't some other confounding factors, we are in that window to give Aunt Betty clot-busting medicines. So these are medicines that go in and help to break up that clot and help restore the blood flow to be able to go past that area of clot. That is our typical, but that needs to be done within 4.5 hours. At least current recommendations are 4.5 hours of the onset of symptoms, which is exactly why we don't want you to go and take a nap and see if it gets better. because it takes time for your workup to get done here, to mix the medications, to get you those medications. And so we don't want you to wait for 4 hours and 15 minutes either. We need you to come in when it's time. The other option that we have in terms of treatment of ischemic strokes are what we call thrombectomy. These are very specific cases. These are for very large strokes and dependent on where it is in the circulation. Not everyone is a candidate for this, and this is why we use telestroke to have you see the stroke neurologist. That timeline can go out to about 24 hours, but again, it's very specific cases that meet those abilities. And this is kind of a diagram of what they would do in terms of a thrombectomy with a little specialized tool that makes its way through the clot itself. So this is sort of a pathway of what you would expect if you are Aunt Betty or you're helping Aunt Betty. You're out to dinner and Aunt Betty has her facial droop. You've recognized it. You maybe have her test her arms and she's weak, or any of those symptoms that you're like, I think she might be having a stroke. And you're going to call 911 and you're going to make this first medical contact. I see that my line got drawn off at the bottom. EMS is going to come out to you and assess you, and they're going to do all those things that we quickly talked about, and then they're going to call in to us in the emergency room and say, I'm bringing in Aunt Betty who has stroke-like symptoms, and they're going to give us the report, and they're going to bring you to us quickly. When you get into the ER, as we said, you're going to go right away and get your CAT scan. You're going to come back. We're going to do a bunch of assessments. We're going to do telestroke, and together with that stroke neurologist, you're going to be evaluated as to would you meet the requirements for those clot-busting medicines, which here we have written alteplase, which is one of those, or are you a candidate for a thrombectomy or potentially both? If you are a candidate for those interventions, those would be done, and then you would be sent to a bigger comprehensive stroke center like St. Cloud or Fargo. St. Cloud is who we telestroke with, so that's typically where we go. And so we would administer those medications as soon as possible. I believe our current record is 27 minutes from the time you hit our door till the time that you got your medicine done. And then we would get you onto St. Cloud where the stroke specialist will be able to follow you. Questions on ischemic strokes? Have I lost you yet? Anybody still awake? All right, hemorrhagic strokes. So these are the bleeding strokes, and they can act very similar to ischemic strokes, but they're treated very differently. When we talk about hemorrhagic strokes, there are those bleeding that's inside of the brain tissue, as you can see on the, what side is that for you? The left side of the picture. Or there's bleeding on the brain or around the brain tissue, which is more common for subarachnoid hemorrhage. So when you look at the left-hand side and we're talking about the bleeding inside of the brain, that's usually an artery that's inside the brain bursts. Or sometimes you have a collection of blood vessels that get irritated, or your blood pressures have been running super high and they cause bleeding inside of that brain tissue. On the right side of the screen with the subarachnoid hemorrhage, these are much more common to be caused by a aneurysm. And so there are different treatments for aneurysms depending again on size and location. Sometimes they will coil them, they'll go up with their little tools and put a little bit of a sort of like a wire coil that causes that to clot off. Sometimes they will clip the aneurysm depending again on what it looks like. But so the treatments for bleeding types of strokes are very different. This is a picture, so with a CAT scan, again, like I said, when you come in with stroke-like symptoms, you go right away to a CAT scan. And the question is this a bleeding kind of a stroke, hemorrhage, or is this not? And ischemic strokes are a little bit harder because they don't show up on CAT scan right away. Oftentimes takes 3 to 6 to 24 hours to show up on a CAT scan. So when you come in quickly, you're coming in so that I can tell whether you have bleeding on your brain or not. Because if you have bleeding on your brain, you're treated very differently than if you don't, and this looks more like an ischemic stroke. So on CAT scan, blood is white, so you can see that area on the left-hand side, actually the right-hand side, but on CAT scan, that's actually your left-hand side. The white is acute blood. It's gone into that lateral ventricle, which are those horn kind of arced areas. And so if we see that, that's a hemorrhagic stroke and you're treated much differently. Certainly not getting any thrombolytics that make you bleed in that case. This is a different type of the bleeding stroke. This is the blood on or around the brain. This is a subarachnoid hemorrhage. This is a massive subarachnoid hemorrhage. But this is blood that's layering on the base of the brain from a ruptured aneurysm. So, other than hemorrhagic strokes, we've covered ischemic, which is the huge majority, and hemorrhagic, which is the other small area of strokes. The last thing to talk about is the TIAs, or mini strokes, so trans-ischemic attacks. And these, we can't call them TIAs until they get better. So they look just like a stroke. We call them a mini stroke. This is your warning sign. This is your chance to say, whoa, something happened to me and that wasn't right. We need to get in and get this checked out, because about 40% or so will go on eventually to have a full stroke, an ischemic stroke. These symptoms last less than 24 hours, and usually they're very short, like a few minutes, 7 to 10 minutes. But it is the typical stroke-like symptoms that we talked about. It's just that they go away. Your body makes them better. Your body pulls apart that little clot that's causing those symptoms. But you certainly are at risk for a full-blown stroke after having had a TIA. So we certainly want you to come in, be seen. We do most of those same tests that we just talked about, and then we make sure that you are set up with either your primary or a neurologist so that we can get some of those other testing. And the goal with that testing is to find out, is there something that we can intervene on to help prevent you from having a stroke down the line? Do you have AFib that nobody noticed and you need to be anticoagulated? Is your blood pressure through the roof? Is your cholesterol way off? Are you many various things. Do you have plaque in the arteries in your neck? There's a lot of things to look at, but this is your warning sign that we want to act on to try and prevent you from having a full stroke. I would be surprised if anyone in here doesn't have 2 or more. I think I have 2. So these are talking about what kind of risk factors do you have and what can we intervene on to help prevent you from potentially having a stroke in the future. Some of these are fully out of your control. You can't control your genetics. What happened here? There we go. You can't control your genetics. You can't control your gender. For women, for whatever reason, we do see that more women die from strokes and a higher risk of disability after a stroke than men. Some of that has to do with your life expectancy being longer. Some of it, I don't know why, but you don't have any control over those things. Your race, certainly African American and Hispanic, we have seen have a higher risk of stroke, but mostly that's due to the risk factors of the risk factors. So, we talk about high blood pressure and high cholesterol. They'll have a higher risk of those things, which then certainly leads into the risk of stroke. Age, of course, if you're lucky enough to live long enough, certainly those numbers go higher and higher. So your risk doubles every decade after 55. But remember, if that 15% in 0 to 40-year-olds, that's not a small number. And if you've had a history of a TIA or a stroke, you certainly are at risk for future strokes. So what can we do? What can we control? And there's a couple of big ones that are similar or the same as your risk factors when it comes to heart disease, and it's all the hard things, right? So blood pressure, certainly we like you in that 120 over 80. When you're in the pre-hypertensive range, there's probably some dietary or exercise or lifestyle modifications that you can do to help lower that blood pressure. But otherwise, we need you to take your medicine when your doctor says that you need to take your medicine. Same thing goes when we talk about cholesterol. So our goal for cholesterol is less than 200 as a total. We want that HDL to be high. That's going to help take care of the rest of the cholesterol. The bad cholesterol, the HDL, helps with how you manage your LDL. Our high levels of LDL are what we don't want. So that's the bad cholesterol that's leading to those plaques that are leading to issues in terms of both stroke and heart disease, as well as various other things. Diabetes, your screening to make sure that your blood sugars are under control. Certainly diabetes is causes a lot of problems with the small vessels, which the brain is small vasculature. And then we want tighter blood pressure control when it comes to diabetes, and your A1C to be under the best control that it can be. So these are all of the usual things that we want you seeing your physician for every year for your annual exam, making sure that those risk factors are under control and that we're doing the best we can. Of course, healthy diet and exercise, all of the hard things, right? So fishes, lean meats, vegetables, fruits, all of the usual, and getting our 30 minutes of exercise as best that you can. Smoking, of course, we can't say enough about quitting smoking if you can, and to talk with your provider if you need assistance in doing so, but that certainly is contributing to vascular disease. So we want to reduce those stroke risks. We want to be able to recognize those stroke symptoms and then respond by calling 911 whenever you need. So I'm going to end us with a couple of the myths versus reality of strokes. Myth being that the stroke is not preventable. And as we've talked about, 80% are preventable by all of those things that we just talked about. Making sure your blood pressures are under control, your cholesterol is treated, that you're eating a healthy diet, that you're getting your exercise, that you're quitting your smoking, all of those things. The one that I hear the most is that strokes cannot be treated. And I hope that that has been drilled across your brain today, that there are things that we can do, but they are time dependent. And so that's why it is so important to get yourself or your family member or your friend that help as soon as it's recognized. So it certainly requires emergency treatment, and we want you there now. Strokes only strike the elderly. As we've talked about, that 15% are less than 40, all the way down to in utero. Anyone can have a stroke at any time. No one is free of the risk. A stroke doesn't happen in the heart. This is a brain attack, similar to a heart attack, but in your brain. Same vasculature issues that we've talked about. And stroke recovery can take a very long time, as some of you know. Between therapies and such, this can be a lifelong slow progress. This is an interesting, I know it's terrible to look at. I don't know, do I have a laser? Oh, look, I do. All right, so as you can see in this picture, maybe it's not going to work. Okay. The dark blue area are the areas that are within 30 minutes of a stroke center. So we are an acute stroke-ready hospital, as are many of the hospitals our size. There's also, so that's the white squares with the H in it, are the acute stroke-ready hospitals. So these are the ones that are getting visits from the state every couple of years that we go through continuous process improvements and monitoring on our results and our timeline and our complications and all of those things. Those are, to be a stroke-ready hospital takes a lot of work. The red square are the comprehensive stroke centers. These are the St. Clouds, the Fargos, and the cities of the world, where those are the places that are doing the thrombectomies and the more advanced treatments for strokes. We see everyone here, we get those medications started with your thrombolytics, with those clot-busting medicines, and then we get you to a comprehensive stroke center. The dark blue is those within the 30-minute drive. The light blue is within a 60-minute drive. So as you can see, our northern area certainly has a little bit of work to do, but I don't know that there's too many hospitals up there anyway. But 94% of Minnesotans can be within 30 minutes of a stroke-ready hospital.